I join here. But I'll turn it over to you, Zach, to introduce yourself and kick us off.
Thanks, Deb. Good morning, afternoon, evening, everyone. Welcome to our Ampath virtual fireside chat tonight. Thanks for being here. I'm Zach Gitlin. I'm the current pediatric team lead here for Ampath Kenya, living in Eldoret. My clinical background and training are in combined internal medicine and pediatrics. My clinical interests are in under-resourced care and advocacy. My personal interests are with my family and my two young children who have just gone to bed. So everyone, if you could contain your exuberance tonight, otherwise I'll find my headphones and we can talk more loudly. I live here in Eldoret with my family. And many of you know our tempo here is to host these serial fireside chats, often quite literally at Fireside this time of year in our dry season, usually up on our hilltop property by a large bonfire. This is a chance for us to come together with our trainees, our faculties, to connect, convene, reflect, have some of those change the world conversations, as my mom calls them sometimes. And tonight we have the chance to meet on a day no less now synonymous with giving and with underminedness, to talk about a topic that's sort of near and dear to me and to all of us, to a growing community here in Ampath, which is critical care for children. There have been a lot of people who've been involved in that effort over the years. We have just a select few with us today, and I'm happy that we're all going to be able to have a round table and a Q&A session virtually here. And hopefully, as people drop in and out, we'll be able to have some very wise individuals share their stories, their history, and give us a glimpse of the future here. Some of those individuals include Dr. Jim Lemons. Many of you will know, neonatologist, professor of pediatrics at IU in Riley. Hopefully, Dr. Audrey Chepkamoy, a neonatologist and really heart and soul of the NICU here at Moy Teaching Referral Hospital. Dr. Brenda Chipkoech, who's one of our phenomenal chief pediatric registrars here at MTRH. Dr. Adnan Bhutta, I see on the call, who's division chief of pediatric critical care medicine at IU in Riley. And I think I see, yes, Dr. Mehdi Mather, who's a regional physician and chief of pediatrics and intensive care at Kaiser Permanente. All of these individuals have been crucial in the past and now involved in our NICU and PICU efforts. And I'm going to ask everyone that I've just mentioned to sort of introduce themselves professionally, personally, include their location now, their connection to Ampath, their current role, and then we'll get started. And as a reminder to everyone before we do, the ample opportunity, I hope, at the end for questions and answers. But feel free at any time to post your questions into the chat, and we'll start to try to field those towards the end. And so, Jim, if you are willing, I think I'm going to pass it to you first to sort of introduce yourself.
Sure, thanks. Thanks, Zach. Yeah, I'm a emeritus professor here of pediatrics and neonatologist at IU. Been here for 45 years. First got involved with Kenya when my wife and two of our kids went over in 1994. Been over, I don't know, 30, 35 times since then, most every year. And then became involved in hopefully developing the NICU, the obstetric program, with the support of lots of people, including our Department of Pediatrics Chair, Rich Schreiner, who I just saw when I got on the phone. And we'll share more later. I hope that's sufficient.
Thank you, Jim. Brenda, I see you on the call as well. Would you be able to introduce yourself and say hello to everyone?
Good evening. My name is Brenda Chepkoech. I am a pediatric resident at Moy University, and I am looking forward to hearing the experiences of my seniors. Thank you.
Thank you, Brenda. It's good to have you here with us today. I don't see Audrey on our call yet. Adnan, if you wouldn't mind saying hello and introducing yourself as well.
Yeah, hello, this is Adnan Bhutta. I'm the Division Chief of Pediatric Critical Care. I am sorry my camera is not working today, otherwise I would have shown you my face as well. But I joined IU about a year ago, and part of the attraction of coming to IU was the work of Ampath in the global health space, specifically in Kenya, because that is also an interest of mine, which is to broaden the net of critical care services being provided in low and middle income countries. So I feel like Moy Medical School and MTRH provide a really good opportunity for us to be able to do that. And so I'm looking forward to working with many of you, both here in India and in other places in the US, and specifically those who are on the ground in Eldoret to make sure that we can realize that dream of being able to provide pediatric critical care for those who need it. So thanks.
Thank you, Dr. Bhutta. And Udit, I think I see you on the call as well. Would you be willing to say hello?
Yes. Hi, Zach. I just got to the hospital here in Southern California, so I'm still sitting in my car. So it's safe. I'm not driving. My name is Mudit Mathur. I'm a pediatric intensivist here in Kaiser Permanente for about the past 8 years. My interest in global health really started with my time at Loma Linda in the 10 years prior to that. And especially with pediatric critical care and capacity building in various locations. And one of the tools for this is the Pediatric Fundamental Critical Care Support class, which prepares non-intensivists to stabilize and take care of critically ill children. So I'm happy that we'll be bringing this class to Eldoret. I was there in September with our first cohort of Kaiser Permanente School of Medicine students, and I was able to see firsthand, the children that were currently being cared for in the adult ICUs, and also the plans for the new PICU there. So I'm really excited to be part of this effort to get the PICU launched. I know Dr. Joram Nyanda is a big part of that. He'll be returning back home next month, and we have plans to hold the first PFCCS class in January, right after the global gathering, and train some of the local folks, including yourself, Zach. If you weren't aware of that, you're going to be one of the trainers for the future as well. And we will then also have another class where we have some of the personnel, the nurses and physicians will be working in the pediatric ICU, so that this can be carried on sustainably in the future. So happy to be part of this effort and excited for what the future brings for children in Eldoret and Western Kenya.
Thank you for being here, Udit. And then last, Laura, you're on the call. Would you be willing to say hello and introduce yourself?
Hi, all. My name is Laura Roll. I once long ago served in Zach's position as the pediatric team leader from 2010 to 2012, and know many of your names on this call. I've stayed involved in both pediatrics and then maternal and child health and population health over the years. I've been working with this group because I've long wanted this group to form. And so I'm super excited that there's a lot of people on this call talking about it, and that I just get to be listening to it at this point.
Thank you, Laura. While we wait for Audrey, for Dr. Chepkamoy to join us, I might go ahead and start our sort of roundtable discussion tonight. And Dr. Lemons, if you're willing, I might have you start us off. Jim, you've had such a long tenure with Ampath. You've seen a lot of milestones since you first came to Eldoret in the 1990s. I know you could fill our imaginations and hours and days with sort of your story, but I wonder if you could sort of compare, contrast for us, or at least give us a sense of some of the things that you've seen away, some of the milestones, how we got to where we are currently.
No, would love to. Yeah, and this is not obviously directly pediatric intensive care, but maybe does have some lessons of what to expect, and a lot of what we didn't expect to happen over the years. But Deb, if you could share the first slide. I just had a couple of pictures from back then, if we can share them. Yeah. So this was back in 1994, so almost 30 years ago. These are the kind of interconnecting wards through the walkways. And for those who haven't been to Eldoret, we didn't have much in the way of laundry services back then, and still sometimes laundry is done. Then next slide. And next slide. Sorry. Yeah, this was the outside of the nursery. So we were particularly interested in the pediatric ward in the nursery at the time. Next slide. My wife worked in the nursery. I worked on the peds ward for those 3 months that we were there. This is a crib where premature babies were put. We usually had 20 in this nursery. That's my wife. We improved rebuilt with the help of a wonderful Sikh man, the inside of this tiny little nursery. We were able to separate babies a little bit. Most of the preemie babies would be in one crib, and by the next morning, many would be septic and die. There's very little that we could do. We had an oxygen tank there, but hadn't had oxygen in it for several years, I think. We didn't have hot water. So we had some of those things through this wonderful friend done. Next slide. And through visiting a number of the private hospitals around, we ended up putting baskets so we could move babies and keep them separated from infection. Next slide. And over the years, we got involved just saying, there should be something better for a pregnant mom to start her life with her child and the father, etc., than just that tiny little room. In the meantime, many things were happening with Ampath. Dave Matthews and Emily Matthews came and helped build the surgical wards. But through we decided to fundraise, my wife and I, and we started raising monies. And then through a lot of help, Bob Einters, Joe Mamlin, Charlie Kelly, Dave Enrique, all helped significantly. And then our chair, when it came to a critical point to raise monies, additional funds, Rich Schreiner helped provide $1.5 million to finish off. We had $800,000 raised to finish this off. And this is what we built. We decided to name it Riley, after our children's hospital here at IU, so that we'd have a permanent academic partnership, because Ampath showed the way, with care. So clinical care first, training, education second, and then research was the third stool. Advocacy would be the fourth. But they always built in from the beginning the importance of prioritizing research, and we wanted to do the same here at the Mother Baby Hospital. So the hospital, next slide. Give a little bit of background. So these are some of the reasons that we thought to have a facility. Ampath wasn't about building buildings, but for a lot of reasons, keeping the faculty there, having a proud place to work, treat patients. If you could go back to the previous slide. It included a vaccine training center and was a huge, also kind of sideline effect on preventing pediatric HIV by preventing vertical transmission of HIV. So as Joe and Bob were building the program around HIV. Next slide. And this is a little bit of what I'm sure Audrey would say. In 2013, Kenya established a policy for free deliveries and expanded to 18,000. Just recently, the Commissioner of Health in Kenya came through and said this is the best NICU all of East Africa, built for 30 babies, has an average now of 130 babies, and 45% of those, because of Audrey and her colleagues' work, are now referrals from different hospitals in Kenya. So lessons learned, first of all, we didn't ever envision this, I don't think, this facility and the comprehensive program successfully. I guess we just didn't imagine that. But because of the embedded care and love, I think, that all of us share with children particularly, but all of the people that work there together, I've always said Ampath is the best of the best, and everything about it seems to be good. It's a great place to turn to mentor and keep altruism alive. But as this progressed, there were a number of important lessons along the way. One was one of our fellows did a research project with educating nurses. So we brought 4 of our NICU nurses from Riley there to teach a small course, 2 weeks comprehensive course in neonatal nursing care, which most of the nurses there knew all of this, but had never been packaged in a short. Just because of that intervention, several things happened. One, we found the mortality of preterm babies, less than 2 kilos, decreased by 50% in the 3 months before and 3 months after we gave that nursing course. The second was that we found one of the keys to the success of a NICU like this was, of course, the nurses. The nurses are the most important, much more important than physicians in kind of keeping healthcare alive. But we didn't have a way in the MTRH to promote nurses and keep them in the unit if they loved NICU, for example. We wanted to keep those great nurses, but to get a raise and promotion, they would have to go to a different ward, the ortho ward, psych ward, the adult male ward, or whatever, and keep moving around. So we kept meeting with the administration every year we went over. We kept meeting together with the nursing staff, physician staff, and the administration. And they developed a way that we could keep nurses who were expert and loved, in this case, the NICU, there. So that was a model that was really important for all of MTRH, so that we keep the best of the best. That was one of many just lessons. One of the great lessons here, when on the first day the hospital opened in 2009, we went up to the postpartum floor and we're sitting there and we were talking to the nurses, and they said, boy, many of the patients, so there's 0.1% that come in and can pay their own way and are wealthy. And they were shocked at the low price and then free care. But many of the other 99.9% of the patients that came in that were in poverty were angry at the nurses because they thought they were being placed on the private ward. And then when they learned that everybody was on the private ward, everybody was treated the same at a very low cost or for free care. It really, that lesson that we should all be treated equally, it just, I guess, was one of the most important that I hadn't appreciated, I guess, the impact of that. And that's true for all of Ampath and MTRH. So I'll stop there. So I just met Bet Kipchumba in December at a coffee shop, and we were catching up. So Bet is now MFM faculty, first MFM fellowship graduate at MTRH. Well, I first met Bet when he was a med student, shortly after the Mother Baby Hospital opened. And his wife went into preterm labor and delivered a preterm boy named Christian. He was born on Christmas 2009. And I hadn't seen Bet in a long, long time. He was a med student then. And I just happened to bump into him at a Java this past December and learned that now he's maternal fetal medicine and helped with the first fetal transfusion in a public hospital in all of sub-Saharan Africa in April. And he showed me pictures of Christian, who's a 13-year-old healthy boy. It's one of the thousands and probably more, connections that we have that show the importance of all the work that Ampath does throughout. So I know I've taken too long, but I'm grateful for the opportunity and everything that's been shared back to us. We're working on many things. We have a chaplaincy training center, the National Chaplaincy Training Centers in the parking lot of the Mother Baby Hospital. None of these things I could never envision happening prospectively, but this is what happens at Ampath. And I know in pediatric critical care, so the NICU provides the kind of core support, but all the other subspecialists are so key. And now we're developing, pediatric fellowship programs in different areas. Ed Lichty started the pediatric residency back 16 or 17 years ago for Kenya at MTRH. All of it is in place for all of the different fields now. And hard to predict where this will go, but it will be wonderful. And we see the impact now on the foundations laid for the PICU to become the best in Kenya. So thanks very much. Hope I didn't go too long.
Not at all, Dr. Lemons. Thank you for sharing. It's wonderful to see the pictures and lay some framework and ground for a lot of us who haven't had the privilege to be there and be alongside as long as you have. So thank you again. Brenda, if you're willing, I'm going to put you on the spot, Dr. Chepkoech. You and I had lunch the other day, and you were making me laugh. You just spent a good amount of time at IU, and you're back here now rotating in the newborn unit in the NICU, and you've seen some pretty stark contrasts, sometimes literally. And I wonder if you could just share with us how your experience is going right now in the newborn unit, and how the differences that you've witnessed in your life recently make you think about what's ahead, what can be ahead.
Thank you, Dr. Gitlin. Thank you very much, Dr. Lemons, for taking us way back up to where we are at this moment. There's a huge difference between what we do here versus what I saw at Riley. First of all, in terms of obviously the capacity from human resource to the available equipment, you have the newest equipment. So the turnaround time is much faster at Riley. Our NICU, it has definitely grown from what Dr. Lemons has shown. And right now I can say, I don't think there's a hospital in Western Kenya that has, I could even say maybe Kenya, that has such facilities that we have. And this is through the work of Dr. Audrey, Dr. Ngetich, our neonatologists, and the other consultants and nurses that we have. So we are really trying, we are getting there. And recently, about a year or two now, we've started doing therapeutic hypothermia for asphyxia babies. And that's it's been a huge game changer. It's very different. And our capacity to manage the very critical patients. I think initially when I joined about 2-3 years ago, we had our ICU, our NICU had seven beds. So for us, NICU is where we ventilate. Then we have the other rooms in the newborn unit for the very preterm. Then the older children, the term babies. So for the NICU where you could actually ventilate, we had about 7, and it has since grown. to about 15, and that makes a big difference. Then also we have several CPAP machines, and that has really changed the patients that are now able to get a chance. Otherwise, they would not have made it. And we're getting patients coming in from several counties around here that come all the way for these services. So it's making a big difference for these children and for these families. So in terms of where we are going, I think the next step is having a PICU, a pediatric ICU, and that's work in progress. We're waiting for Dr. Nyandat, and through the training by Dr. Mudit, I think it was a good experience. And what I saw at Riley after that training, I had already rotated in the ICU. And after that training with Dr. Mudit, some of the things that I saw at Riley ICU made a lot of sense. And I think once we set up and we have several of these short courses and others go for training, I think it will be good for our children also. Yeah, thank you.
Thank you, Brenda, for your stories and perspective.
Could I just add one comment? I really appreciated Brenda's. I wanted to emphasize, I hoped Audrey would be here by now, but we didn't have a neonatologist, Kenyan neonatologist, for quite a number of years. And Ampath has taught us patience, I think. So we didn't have ventilated babies until we had the staff there. When Audrey joined us and finished her fellowship in South Africa and came back to Eldoret and joined us, she is one of the most amazing, wonderful human beings and best physicians. And Dr. Nkatich joined recently to staff the NICU. And then we have a nurse practitioner, Evelyn, who also trained in South Africa and came back to help with a lot of this support. And it's really entirely their efforts and leadership that have enabled this to happen. We in the US and in Toronto, etc., I think watch this and are inspired and fall in love with it and want to raise funds to help support it. But it really is the leadership and the day-to-day amazing work that they do. And in the NICU, Audrey is really the champion of all of this. And I wanted to make sure that was included. And they have elevated the care now, giving surfactant, now doing cooling. And something I never imagined would happen, they just this year started the neonatology fellowship. The MFM fellowship, Toronto helped start back in 2000, I think 19, maybe 18, 19. And we just started this year, but Audrey, they got approval, a lot of it with Julia Songcock's support and all the other colleagues. But I couldn't believe it that we have now Kenyan neonatology fellows training them.
Thank you, Jim. It's such a wonderful point. Audrey deserves such recognition for, I think, her care and devotion. In my short time here, rounding with her in the newborn unit, she's taught me so much, very little of it clinical and most of it just her demeanor and her approach. She's very hardworking and incredibly balanced and is quite an inspiration. You and Brenda bring up great points about sort of next steps and where we go from here and seeing what the future holds. And I think with that, Dr. Bhutta and Dr. Mathur, if you're willing, I have a sort of a question to you. I think there are so many models of health capacity building and global health that often tier interventions in healthcare. We build frameworks where we say sanitation and clean water, nutrition and vaccination and primary care come first, and then hospital-based emergency care, and that critical care resources are often very far down the line because their implementation and practice are inherently complex. It takes a lot of specialty training and exhaustive diagnostics and costly therapeutics. And now we've seen other fields kind of come into the fray of universal healthcare coverage. Universal health coverage, we've seen sort of global surgery. And I'm curious, where are we with pediatric critical care? What does it mean to have a PICU? And what is it that makes now the time to do this at MTRH? What makes this sort of a cause to invest our efforts in?
So Zach, that's an excellent question, and I think that was, historically that is why pediatric critical care really hasn't been given the attention by policymakers for the longest time, because when you have fundamental issues like water and sanitation, vaccine availability, nutritional supplementation, all of those, primary care things that we sort of incorporated as primary care. When you don't have enough dollars to get that going, then it's almost comical to speak of setting up critical care units. But I think as the world has evolved over the especially last 30 years, I would say have been, really, that's probably the most progress the world has seen in a concerted way around any one topic is around sort of healthcare and improving health for all in that time frame. And we sometimes get so despondent about the world that we fail to see the immense success that I think we all as physicians have really been a witness to in the last few decades. It really has been amazing, the bringing down the estimated childhood mortality from 13, 14 million annually to now less than 4 or 5 million is nothing short of a remarkable success of sort of a really global concerted effort. But I think the next moving beyond primary prevention is really what needs to happen to bring the overall burden even lower, right? So bringing down the mortality burden, but also the morbidity burden. And I think that's where critical care is going to have its role. You cannot have a global surgery initiative or a global HEMONC initiative or a global nephrology initiative and all these other initiatives that are happening without having some sort of critical care infrastructure. You also cannot at some point be able to provide care for children with lower respiratory tract infection, which currently are the biggest reason for childhood mortality is pneumonia or lower respiratory infections, without having some basic critical care infrastructure like CPAP machines or high flow devices, or because no matter how good we get at making vaccines, there will always be bacteria and viruses that we won't have a vaccine for. And if you look at our, the top 20 causes of pneumonia or bronchiolitis, we only have vaccines for 2 or 3, right? So everything else healthy children will still get sick and they will still be critically ill, and some of them will still die unless there are supportive measures available to prevent that from happening. And then I think that's another avenue where having a critical care unit is I think essential. It doesn't have to be the replica of the PICU at Riley or at Kaiser, but and it can be gradually built up over time. But I think starting off with basic facilities like improved monitoring, like delivery of non-invasive ventilation and some degree of mechanical ventilation, I think would be the first step where I would, and then just better trained personnel. I think, we focus so much on stuff, as Paul Farmer would say, but there are really, what he talked about was it 4 elements, right? Of the 4 S's of a healthcare framework. Part of it is stuff, but the other part is staff and systems, right? And I'm blanking on the 4th one, but they will come to me. But there's so I think training your staff, which Modit is sort of so kind in leading the PFCCS courses, but it'll have to be an ongoing endeavor, right? It's not just PFCCS once or twice or 3 times a year. It'll have to be ongoing training, ongoing attention to details about how the system works at Aldoret and in other places. So I think the reason, to sort of sum up the answer to your question, I think it is the right time, because I think the world has gotten much better at delivering primary care and is very interested in delivering specialty care. And I think as part of that, you have to have some sort of a critical care infrastructure to support all of that. I'll let Mudit add to, I'm sure he has thoughts as well.
Yeah, I couldn't agree more with you, Adnan. I think also we know that MTRH and Shoe for Africa are already in a different space with hemonc care being provided, neurosurgical care, and other surgical specialties already in place. I think what needs to be added to it is the monitoring, early recognition of critical illness and support that an ICU can provide. So it could be simple things like oxygen, could be fluids, could be early antibiotics. I mean, there are children on the hemonc ward that potentially have a 95 or plus % cure rate for the leukemia, but they might succumb to sepsis if it's not recognized and treated early. And I think those types of situations, critical care unit can provide the close monitoring. I think that's really essential for some of these patients, and the early recognition and treatment. So it doesn't have to be sophisticated machinery or sophisticated interventions to begin with. I think a lot of bang for the buck can be achieved by simple measures, and I think the ongoing sustainability of the training is exactly what we're trying to achieve too with the PFCCS model. As Adnan mentioned, this is not a one and done deal. This is something that will require ongoing effort, and that's where having the local trainers capable. Brenda and Joram have already attended PFCCS, and they are in a position to become official instructors for SCCM and carry the torch forward. So I see great things happening at Shoe for Africa in the near future.
Thank you both for your candid answers.
Zach, sorry.
No, of course. Hi, Michael. How are you?
I'm good. Sorry to interrupt you. I just wanted to add a couple of things. I'm Michael Littner Rivera. I'm a pediatric intensivist at Riley as well, and work with Adnan, who is my boss. And I think, definitely wanted to echo some of the sentiments and thoughts of Adnan and Mudit. And I think that, pediatric, or I guess critical care in general, has been kind of lacking in the global health space. And I think the questions that you brought up are very legitimate. And I think some of, the answers that Adnan and Mudit gave are certainly valid. I think that the timing of COVID pandemic too, I think highlighted the importance of critical care, throughout the world. And I think that's, I guess, maybe a silver lining. I really hope and suspect that critical care, I guess the critical care's maybe footprint in global health will increase in the next decade. And I think we're already seeing that, because as you mentioned, and Adnan mentioned, um, when and where do we start providing acute or critical care? I think is a great question. I think it's a lot of it has to do. I don't know. I by no means will have all the answers to these questions, but I think it's the way that we think about them, and frame the delivery of this care. If it's too complex, then certainly I think resources are going to be allocated elsewhere. But and so I think it's just framing it, right? Because high flow nasal cannula, CPAP aren't that complex. Certainly managing a patient with ARDS and septic shock on a ventilator and multiple pressors is a very complex patient. But I just recently got off a week of service in one of our community PICUs where I had, I don't know, 10 patients a day on high flow nasal cannula with RSV who are all going to be fine. And I think that, that those, I guess, stepwise interventions in getting to a more complex PICU, I think are certainly absolutely necessary. And I think those steps are already being taken. But I think it's just changing the mentality of it, and changing, I think, from what I gather is that people don't think it's necessarily that it's cost efficient, maybe, and that resources are better allocated elsewhere. But I think that, and to follow along what Adnan was saying and talking about Paul Farmer, PIH, I think, changed the mentality on how you think of, let's say, antiviral treatment for AIDS in sub-Saharan Africa, right? I think 20 years ago, it was considered not cost effective to treat patients. And I think that they demonstrated that indeed it was cost effective. And I think hopefully that's going to be the case with critical care in the next few decades. That's my hope anyways. And it's kind of an exciting time to be in critical care and global health. Thank you.
Thank you, Michael, for sharing. I mean, I think it's an exciting for all of us, and specifically with this opportunity. Yeah, go ahead, Jim.
Yeah, it was all of this is reminding me in 1995, the first group of 5 fifth-year Kenyan students came over for 2 months to rotate at IU. And at the end of the 2 months, we invited them to share at our church just over lunch. So we had a couple hundred people there listening, and each one got up. I asked them just to share reflect on a couple of their thoughts and experiences in the US versus Kenya, etc. The last one to get up was Eric. I'm blocking his last name, tall, handsome Kenyan student. And he said, coming here was like stepping into a time machine and coming ahead 50 years. He said, while I was here, I got to watch a switch procedure, which we had just started doing at Riley for transposition of the great vessels in the first week of life in a newborn baby, switching the aorta and pulmonary arteries. He said it was the most amazing. He said, I knew of the switch procedure, but it was a dream. It wasn't real until I saw it happen. He said, tomorrow we are leaving to head back to Kenya. We're going back 50 years. He said, but someday I know that this is now possible. It was a dream before, saw it in books, but now I know this will happen back in Kenya one day. And this reminds me, this is the time, for PICU and all the expertise we have available here. It's really awesome. The future is going to be very, very bright, and this will make a huge impact. Thank you.
Thank you, Jim. Dr. Njuguna, I see you on the call. I don't want to put you on the spot, but you've been a part of the fabric at MTRH for so long. You've seen the newborn unit come to fruition and the CCU, and I wonder if you have thoughts about your experience or hopes with the PICU.
Thank you, Zach. And yes, as you rightly put it, I've seen it all growing, and appreciate Professor Lemons for the pictures that he showed from where we started with the newborn unit and small course. I was there as a student, and even now when the new Riley, the baby hospital was constructed, I was there. And as been mentioned, we've grown a lot of other specialties. And I think the importance of having the capability to offer intensive care services has become greater than ever before. I think when you offering oncology services, for example, newborn services, surgical services that are specialized, you really need to have a good intensive care so that you can have these babies survive. So sometimes, for example, if I say in oncology, sometimes we have patients who need surgery for brain tumors, and they have to wait for 2-3 weeks waiting for an ICU space in the space that we co-share with adults. Of course, that leads to reducing their chances of surviving. So having critical care for pediatrics would be absolutely good. And I think we already have some things in place. We are getting people trained. We just need to keep working on getting the right mindset amongst ourselves, having nurses who can work in that unit. And we can do this as we've done in oncology or newborn services, where you have nurses who work in the unit for several months and years, and they get hands-on experience even before we get those who have gone for specialized training. And that, coupled with doctors who are willing to work and deliver, will lead to having a great unit, I believe. So yes, we need this, and we need to have this training for both medical students and residents, so that even as they exit the system, they have the right skills to provide critical care for pediatrics. Thank you.
Thank you, Dr. Njuguna. It's wonderful to have you here this evening and to hear from you. We've heard a lot tonight, and there's such a wealth of experience and perspectives on the call, and I do want to open the floor to sort of general questions and answers. I know that we're going to put information in the chat. We'll put a link for donation opportunities, particularly on this day of giving. I think many of you have probably heard that on this day, many of your donations will also be matched to try to reach a certain goal for Ampath, and specifically for Ampath Kenya here. And I can promise you, as can many people on this call, that a lot of that will directly impact patients on an individual basis, and for these larger scale training and care initiatives that we have here in Eldoret. Before we do get to the questions and answers, I do just want to thank everyone, Dr. Lemons, Dr. Chepkoech, Dr. Buddha, Dr. Martyr, and Dr. Njuguna. And thank you everyone for attending. I'll give everyone the grace to sign up and go about your day as in if you need, but like I said, we'll also continue the conversation here with questions and answers for as long as people are interested.
I can chime in just to say thank you. This has been a great conversation, and I'm really excited about the progress and momentum this group has made. I think over the last 8-9 months, starting with Julika Kaplan when she arrived as a pediatric team leader, this group has really come together and created a plan to move forward at an exceptional pace. And I think there's funding in place for hopefully developing a PICU fellowship down the road. And in order to be able to be successful, we need to have a functional critical care space for kids in order and to be able to educate future leaders. So I think we've got the right team, but clearly need more Kenyan support in the hospital system. But as Jim Lemons has shown, you can be hugely successful in creating that team. And now the Riley Mother Baby Hospital is really independent and functioning like a NICU. So it's exciting.
Can you hear me?
We can.
Yeah, my name is Jeff Richardson, and thank you so much. I really enjoyed the discussion. One of you referenced Partners in Health and some lessons learned from Paul Farmer. And I know you've had some collaboration with them over the years, and the Baylor College of Medicine has done a lot of work in the pediatric space as well. I'm just wondering generally what, besides the incredible work you're doing in Kenya, I wonder also, I'm at a doctor's office. They just called me. What timing? I wondered what kind of collaboration you've done over the years with other great organizations like Baylor and PIH to advance your work.
Thank you, Jeff, for the question. Laura or...
See here, we'll get started. Okay, I'm going to have to go, but I think other people might appreciate your answer, and my doctor now is here, and keep up the good work. Thank you so much.
Thank you, Jeff. Good luck.
Bye-bye.
I'm happy to chime in here since I jokingly made the PIH nudge on the chat. Of course, I completely respect PIH, and that was just a joke. But I think there could be so much more collaboration with like BiPi, Baylor, or PIH. I think each of our organizations have been working so hard in the areas we focus. We often, especially I know since I can speak for Ampath, and those of us living in Kenya haven't spent enough time looking up and working with other partners in this area. And so I think right now a lot of focus has been placed on focusing on the collaboration and consortium as it's expanding to Ghana, Nepal, Mexico, and Ghana, Nepal, and Mexico, and new consortium partners like Louisville joining those endeavors. But Ampath is always interested in improving collaboration rather than recreating the wheel or independently going about something. And so I do think that especially in pediatric critical care, learning and working together with people all around the world doing this is going to be hugely important. And I can invite Adrian if he has more thoughts, because he might be able to speak beyond the areas I know in Ampath. But certainly in the HIV world, we've had a lot of collaboration.
Yeah, Laura, thanks, Laura. I don't have a lot to add, just to say that, at this, yes, absolutely underscore that, but at the same time, everything is local. And, working with our Kenyan partners and following their lead has really been a critical part of our success. And obviously, this is a really exciting time to have Dr. Nyandat and the other faculty and team in Kenya who are really able to lead this effort and really creates all the necessary ingredients for a recipe for success. Thanks for putting this together, Zach and Deb.
Oh, of course. And thank you, Adrian. Thank you, everyone, for joining this evening. Exciting to keep this conversation going and see where this goes. Like I said, if there are other questions, I'm happy to stay on with anyone else who would like to and field them. And for the rest of you, please enjoy your day, this Giving Tuesday, and be well.